Every year, thousands of women pay thousands of dollars to trim, laser, and, tighten their most intimate
Right,
areas.
often chasing a very specific, almost prepubescent aesthetic.
Exactly. But what if the feeling of looseness that's driving them to the clinic in the first place isn't just like stretched skin?
Right.
What if that sensation is actually the primary symptom of a massive structural collapse happening inside the pelvis? Welcome to the deep dive.
Yes, welcome.
We are taking that exact scenario and applying it to this booming trend in the medical and aesthetic world. The core question we are exploring today is this: can cosmetic concerns actually be masking a serious underlying medical issue with the pelvic floor?
And to get to the bottom of this, we are synthesizing a really detailed stack of sources for you.
Yeah, we've got some great material today.
We do. We're looking at clinical guidelines from S2, it's the National Institute for Health and Care Excellence, alongside data from the Royal College of Obstetricians and Gynecologists.
Plus, we've got some biomechanical insights from frontline pelvic floor physical therapists, right?
Exactly. And some remarkably blunt anatomical commentary from specialized urogynecologists.
Okay, let's unpack this. Because there is a glaring, almost dangerous contradiction in the clinical data right out of the gate.
There really is.
On one hand, you have this massive surging industry capitalizing on patients seeking out surface-level cosmetic procedures. Things marketed under names like designer vaginas or barbaplasties.
Which is just a wild term.
It is. And they're primarily doing this to fix a perceived wide gap or vaginal laxity. But on the other hand, the clinical data from INSS explicitly tells us that up to 50% of women actually have some degree of pelvic organ prolapse.
Half the population.
Right. So are we basically just treating the paint job when the foundation of the house is actively crumbling?
That statistical contradiction is really the crux of the entire issue. We have to draw a hard line between what patients assume is happening versus the actual biomechanics of the pelvis.
Right, the reality of it.
Exactly. When someone walks into a cosmetic clinic seeking these treatments, the chief complaint is almost always vaginal laxity. So a subjective sense of looseness.
Usually happening after childbirth or like massive weight loss, right?
Yeah, precisely.
And the symptoms described in these clinical surveys are incredibly specific. A patient might complain of passing wind from the vagina when they bend over or lift something heavy.
Or they might actually feel a visible bulge at the opening.
Yeah. Others report that excess tissue is causing friction and irritation with their clothing. So naturally, they seek out a tuck or a trim, assuming it's just a surface issue.
Which makes sense from their perspective. But marketing language is heavily responsible for muddying those waters.
Oh, absolutely.
Terms like rejuvenation completely oversimplify the reality of highly sensitive functional tissue. To give you a specific example from our sources, Professor Helen O'Connell, she's a prominent urological surgeon, issues a stark warning about this.
What does she say?
She points out that the tissue excised in a standard labiaplasty might look like, quote-unquote, just skin to a cosmetic surgeon. But the labia minora are derived from the primordial phallus.
Wait, meaning they share the exact same embryonic origins as the clitoris?
Yes, exactly.
Yeah.
They aren't just extra flaps of skin. They are biologically engineered for sexual response.
Oh, wow. So you can't just snip them off without consequences?
Not at all. They are packed with specialized nerve endings, complex vascular compartments, and epithelial qualities that are absolute prerequisites for sexual arousal and orgasm.
Right.
So excising that tissue to meet a temporary aesthetic trend heavily interferes with sexual pleasure. Furthermore, the clinical guidelines note that the aesthetic ideal is a moving target.
Like fashion trends.
Exactly. What is heavily promoted as the ideal look today will likely shift in a decade, but the surgical removal of that vascular tissue, that's permanent.
But let me push back on this a little bit because I am looking at the demand for these procedures. If a patient genuinely feels loose after having a baby and they are experiencing that friction and discomfort, why not just tighten the entrance?
I see what you're getting at.
Like, think of the pelvic floor like a suspension bridge. If the cables feel a bit slack, what is the harm in taking in the seams a bit? Just tightening the anchors at the base to give them some tension back.
Well, what's fascinating here is that the sensation of looseness is almost never an issue of slack skin or a loose anchor.
Wait, really?
Yeah. According to the clinical data, that feeling is very often a direct symptom of a levator ani muscle avulsion.
Okay, looking at the RCOG data here, an avulsion implies the muscle is completely sheared off the pubic bone.
Yes, detached.
How is a patient walking around with a detached muscle and just thinking they need a quick cosmetic tightening Wouldn't they be in severe acute agony?
You would assume so, right. But the pelvic floor is notorious for referring pain and masking structural failure as generalized heaviness.
Oh, interesting.
Or it masks it as a lack of sensation or that feeling of looseness. The pelvic floor is a dynamic basin of muscles, and the levator rani is the primary sling providing upward support to the vagina, uterus, bladder, and bowel.
So it's holding everything up.
Exactly. So when that muscle shears off the bone during childbirth trauma, the biomechanical fallout is staggering. This avulsion weakens the entire pelvic floor muscle complex by about a third.
A third? That's massive.
It is. And it makes the remaining muscle 50% more stretchy.
Right.
Most critically, it enlarges the opening of the pelvic floor, the hiatus, by a full 25%.
So the actual anatomical gap at the bottom of the pelvis is a quarter larger than it structurally should be, and the patient just perceives that as needing a surface tuck.
Yes, unfortunately.
Oh.
And because of that lost structural integrity, it more than doubles the risk of the bladder prolapsing or falling into the vaginal canal.
Oh my God.
And it triples the risk of the uterus prolapsing.
Okay, if we establish that laxity is actually a massive structural failure of the levator ani muscle, that completely reframes the cosmetic conversation.
It absolutely does.
Just have to look at the mechanisms of why snipping skin or tightening the superficial entrance fundamentally fails to solve the underlying prolapse.
And for that mechanism, the sources point us to a brutally honest assessment from urogynecologist Dr. Marco Pelosi III.
Yeah, his commentary was fascinating.
He was asked directly, does repairing vaginal laxity or a wide gap provide any actual support to the pelvic organs?
Yeah.
His answer is absolute. No, it does not.
He draws a very sharp anatomical line between cosmetic repairs and traditional reconstructive prolapse repairs.
He does. He clarifies that cosmetic repairs focus on reducing the caliber, so the diameter, at the superficial level of the perineal muscles.
Right, surface level.
But true prolapse repairs focus on lifting the vaginal supports at the level of the endopelvic fascia.
And the fascia is the deep, tough connective tissue that actually acts as the internal suspension cables holding the organs in place, right?
Exactly. Snipping the surface muscles does absolutely nothing to reinforce that deep fascial support.
His exact quote from the sources is incredibly vivid. I have it right here. He states, "The perineum is that last structure between the pelvic organs and the outside world. And if that structure is broken, your pelvic organs are headed on an unplanned trip to the outside world."
And an unplanned trip to the outside world.
It is a terrifying image.
Terrifying, but entirely anatomically accurate. If a patient has a rectocele, where the bowel is leaning into the back wall of the vagina, or a cystocele, where the bladder is leaning into the front wall, doing a superficial muscle repair at the entrance is like putting a piece of tape over a bursting dam.
Because the organs are still descending?
Exactly. As Dr. Pelosi put it, substituting a surface muscle tuck for a necessary organ repair historically leads to severe dyspareunia, or painful sex, and incredibly high failure rates.
Here's where it gets really interesting, especially when you look at the financial.
Oh, yes.
Yeah.
The insurance side of things.
Yeah, you might be looking at the high satisfaction rates advertised on cosmetic clinic websites and wondering if it doesn't structurally work, why are the reviews so glowing?
Right, it seems contradictory.
Look, the distinction between aesthetic goals and reconstructive necessity dictates medical insurance coverage. Dr. Pelosi notes insurance companies will never cover cosmetic procedures for what he bluntly calls lousy sex.
Because the medical necessity just isn't there.
Exactly. The high reviews are often due to a temporary tightening effect, like a placebo response, before the underlying structural failure inevitably overtakes it.
Which logically drives a huge segment of patients toward a different market entirely.
The devices.
Yes. If surgical reconstruction is invasive and cosmetic surgery won't hold the organs up, patients are caught in a desperate middle ground. That desperation is exactly what the non-invasive energy device market is capturing.
We are talking about fractional CO2 lasers and radiofrequency treatments, right? The ones aggressively marketed for vaginal rejuvenation.
Those are the ones.
You see ads for these everywhere. It's pitched as a lunch break procedure, sit for a laser treatment, walk out, and your tissue is instantly rejuvenated. But looking at the histology in our sources, what are these devices physically doing to the cellular structure?
Well, we have to acknowledge the cellular science first. They are not snake oil.
Okay, so they do something.
They do. When a fractional CO2 laser is applied, it vaporizes water in the tissue, creating microscopic thermal injuries in the vaginal mucosa.
So it's essentially burning tiny holes in the tissue.
Controlled thermal damage, yes. And this forces the body's immune system and fibroblasts into overdrive. The fibroblasts start remodeling the extracellular matrix, laying down new type I and type 3 collagen.
Okay, so new collagen means firmer tissue.
Right. Based on retrospective clinical data, this neocollagenesis genuinely improves vaginal moisture, enhances local tissue tone, and can resolve symptoms of mild stress urinary incontinence.
The operative word there being mild.
Very mild.
Like, they can improve the mucosal lining, but they definitely aren't rebuilding a detached muscle.
Precisely. And the massive red flag raised by specialized clinics and our sources is this protocol. The safest starting point is never the device. It is always the diagnosis.
Because you cannot just fire a thermal laser at a symptom without knowing the underlying pathology.
Exactly. If you bypass a proper medical workup, you could be masking a malignancy.
Yeah.
You absolutely have to exclude pregnancy. You must investigate any unexplained bleeding, which could indicate endometrial issues.
Or rule out active infections.
Yes. And the sources specifically highlight device uncertainty. Like, if a patient has an IUD and the strings are missing, you cannot blind fire a laser into that environment without a transvaginal ultrasound to locate the device first.
That sounds incredibly dangerous. And, there is a massive diagnostic paradox in the research that blew my mind when we were reviewing these sources.
A hypertonic issue.
Yes. So a patient comes in complaining of a wide gap or severe friction or painful sex. They assume, and a less scrupulous cosmetic clinic might agree, that the pelvic floor is hypotonic.
Meaning it's underactive, loose, and needs tightening.
Right. But the physiological reality is frequently the exact opposite. Sometimes those exact symptoms, the pain, the feeling of dysfunction, the friction, aren't happening because the pelvic floor is too loose.
It's just too tight.
Exactly. It is hypertonic.
This is perhaps the most dangerous misdiagnosis trap in the entire aesthetic industry. A hypertonic pelvic floor means the muscles are in a constant, relentless state of spasm or excessive tension.
They just can't relax.
They have lost the neurological ability to relax. This state can be triggered by birth trauma, pelvic inflammatory disease, endometriosis, or even chronic psychological stress, where the patient habitually grips their abdominal and pelvic muscles.
The best physiological analogy for a hypertonic pelvic floor is to imagine making a tight, white-knuckled fist with your hand and just holding it there.
Right.
Not for a minute, but for days, weeks, or months. Your hand isn't going to feel strong. It is going to feel weak, exhausted, trembling, and incredibly painful.
It would be agonizing.
And if you then try to use that hand to open a jar, it will fail. Not because it lacks muscle mass, but because the muscle fibers are completely maxed out and fatigued.
That is a perfect visualization of the biomechanics. So imagine a patient with a hypertonic pelvic floor, that exhausted, clenched fist. They experience pain and weakness. They go online, read a few cosmetic blogs, assume they are loose, and follow generic internet advice to perform hundreds of Kegel exercises.
Oh, no. So you are telling a spasming, exhausted muscle to clamp down even harder.
Exactly.
What happens to that clenched fist?
You trigger immense localized pain, and you actively worsen the dysfunction. You are reinforcing a pathological spasm.
That's terrifying.
It leads to severe validynia, chronic constipation because the muscles won't release to allow bowel movements, urinary retention,
Yeah.
and it makes sexual intercourse completely agonizing, if not impossible. This is exactly why a surgeon or esthetician cannot simply look at a patient's external anatomy and decide to tighten them without an internal functional assessment. You cannot mechanically tighten a muscle complex that is already screaming from tension.
So if blind cosmetic surgery ignores the fascia, and firing a laser at an undiagnosed problem is a massive liability, and generic Kegels can actually backfire, what is the evidence-based roadmap for actually reclaiming pelvic floor health?
Right, where do we go from here?
Where does a patient safely start?
Well, if we connect this to the bigger picture, the NICE guidelines are incredibly robust on this exact pathway. The mandated first-line defense for pelvic floor dysfunction is non-surgical management.
Okay.
And the absolute cornerstone of that protocol is specialized pelvic floor physical therapy.
Which, to be clear to you listening, is infinitely more complex than a doctor just handing you a pamphlet on Kegels and sending you home.
Oh, it is an entirely different discipline. A specialized pelvic floor physical therapist performs a comprehensive internal and external neuromuscular evaluation.
To see what's really going on.
Exactly. They map out whether your muscles are hypertonic, hypotonic, or simply uncoordinated. If you have that hypertonic clenched fist floor, they utilize internal manual trigger point release techniques and biofeedback to train your nervous system to drop the tension.
And what if it is hypotonic?
If you have a hypotonic, weakened floor, they use graded resistance to retrain the muscles to contract optimally before you cough or lift.
So it's very targeted.
Very. And in a vast number of cases, resolving these neuromuscular deficits can completely manage mild to moderate prolapse and negate the need for surgery entirely.
That's incredible. And the sources heavily emphasize that you, as the patient, possess a massive amount of control over the biomechanical variables that impact this too. Basic lifestyle modifications alter the physical load placed on your pelvis.
It fundamentally comes down to physics and managing intra-abdominal pressure.
Right. So losing excess weight directly reduces the sheer gravitational strain on the endopelvic fascia. Quitting smoking is paramount, and not just for the obvious pulmonary reasons.
The coughing.
Yes. A chronic smoker's cough repeatedly forces sudden, violent downward pressure from the diaphragm directly onto an already compromised levator ani muscle.
It's like a hammer blow every time you cough.
Exactly. And managing your diet to absolutely avoid constipation is non-negotiable.
Chronic straining on the toilet acts like a battering ram against the weakened vaginal walls. The Torbay and South Devon NHS Trust actually provide specific biomechanical visuals on proper toileting posture.
Oh, the squat stools.
Yeah. Elevating the feet on a stool actually alters the anorectal angle. It straightens the lower bowel to facilitate emptying without that destructive downward bearing.
But let's look at the patients where physical therapy and posture adjustments just aren't enough. Say the prolapse is anatomically advanced.
Right, that happens.
The patient is experiencing that heavy, dragging sensation or physical bulge, but they are terrified of major reconstructive surgery, and they know cosmetic surgery won't hold. What is the bridge there?
That is where the pessary becomes a profoundly elegant medical solution.
A pes?
Yes. A pessary is a medical-grade silicone device inserted into the vagina. They come in dozens of shapes, rings, cubes, Gellhorns, specifically tailored to the patient's unique internal anatomy.
So it essentially acts as a localized internal scaffolding system.
Exactly. It redistributes the mechanical load. It physically supports the bladder, uterus, or bowel, transferring the weight off the damaged fascia and onto the pubic bone or the remaining levator sling.
That makes so much sense.
It is suitable for almost all stages of prolapse, and the moment it is inserted correctly, it can instantly alleviate that dragging sensation.
And the success rates are pretty high, aren't they?
The clinical success rate is remarkable. Approximately 85% of patients are successfully fitted for a pessary. Many can be managed entirely by the patient, removed for cleaning or intercourse, and they provide immediate structural reinforcement without a single surgical incision or laser burn.
So what does this all mean for you listening right now?
It's a lot of information.
It is. But it means that if you are experiencing physical changes, feelings of looseness, friction, a wide gap, or a heavy dragging sensation, do not let slick cosmetic marketing convince you that your anatomy requires a superficial surgical tuck or a quick laser rejuvenation.
Right.
Those aesthetic complaints are very often the primary alarm bells for a deeper medical pelvic floor dysfunction. You cannot treat a foundational biomechanical failure with a surface-level cosmetic solution. You have to demand a comprehensive diagnostic assessment of your pelvic muscles and fascia first.
And that brings us to a final lingering thought drawn directly from the sources. A recent survey analyzed women aged 25 to 45 who had experienced vaginal changes post-childbirth.
What did they find?
The data revealed that 50% of them wanted a non-surgical tightening procedure. Yet these exact same women admitted they didn't even know how to articulate their experience of laxity.
Wow.
They lacked the anatomical vocabulary to describe what was happening to them, and they were terrified of being dismissed by the medical establishment.
That is so sad.
It raises a massive question for you to mull over. Is the booming designer vagina industry simply capitalizing on the fact that women have been systematically undereducated about their own basic pelvic anatomy? Are clinics just selling a fresh coat of paint precisely because no one ever taught patients how to inspect the foundation?